I want to get now to a question about testing, the issue that never seems to go away. There was a story last weekend in the New York Times that questioned whether the standard diagnostic tests for COVID-19 are too sensitive and are diagnosing too many people with quote unquote relatively insignificant amount of the virus. Mike, what did you make of this story?
Well, this story has received a fair amount of attention because it suggested, and as I quote in this story, that basically many of the positives that we see today by PCR are not infectious. In fact, the exact quote from the article was, on Thursday, the United States recorded 45,604 new coronavirus cases, according to a database maintained by the Times. If the rates of contagiousness in Massachusetts and New York were to apply nationwide, then perhaps only 4,500 of those people may actually need to isolate and submit to contact tracing. So it's 4,500 to 45,000. Unfortunately, I have some familiarity with the data that had been used, particularly from the state of New York, and this group just made an error. To better understand what happened here is when you do polymerase chain reaction testing, what happens is they use a cycle where they're trying to amp up the amount of genetic material, thereby reproducing it. So one copy goes to 2, 2 goes to 4, 4 goes to 8, 8 goes to 16, 16 goes to 32. And you do a number of cycles till you get enough that you can actually detect. And cycle times less than 35, meaning you amped it 35 times, have always been considered, in a sense, positive. You have it. Meaning fewer cycle times means it's more likely there because you already could pick it up with very few cycles. If you get more than 35 cycles, then it means that basically it may be not there, or there's so little of it you just can't see it or find it. The problem with this article is that they made a mistake. I don't know how, about exactly the proportion of positive PCR test results that have cycle times less than 35 or over 35. And so their conclusions were not valid. They did have data from Massachusetts that I was unable to review and don't know what those data showed, but I'm also aware of data from other state health departments that were consistent with what we saw from the New York labs. And I think this article will be undergoing formal review inside the New York Times in the next few days to challenge some of these questions that were raised here. In addition, one of the areas that they missed, which I'm not sure how, but think today what happens with someone who is tested and found PCR positive. More often than not, we wouldn't retest them again, knowing what we know today. But if you look at the duration of the pandemic so far, a lot of people who were initially test positive got tested multiple times later until they cleared. So I might get tested on day 4 of my infection and have a cycle time of 29, pretty infected. But then when I get tested on day 10 and day 12 and day 14 and trying to make sure I'm cleared that PCR positivity, because at the time we didn't know for certain that really wasn't associated with infection, my cycle times might be, 38, 40, somewhere in that range that would give me that very low positive. But that's not a new person. That's not a new test. In a sense, it's me. And so we don't really know among those tested here how many of them were retests that could have very high cycle times, 38, 40, that would have not really been representative of what a new infection was like. And so I just want to point out that we have a lot more to do. I'm the first to agree that it is important to understand how infectious someone is, when are they most infectious, but I don't feel like this study got us there. We will be doing work with several state health departments to look at just what cycle time data is available for PCRs. And I think you're going to find that the vast majority of them have always been under 35, and that the conclusions in this article will be challenged. I also want to just address the fact that last week I received a number of very good comments and questions about helping me understand why I had concerns about this idea of using these cheap tests, the dipstick kind of thing, on a voluntary basis. And there were legitimate concerns that obviously I didn't do a good enough job explaining this, or if I did, it didn't matter. But first of all, let me just point out that, I'm one of these guys that I care about the big picture in the saying, how many cases are we going to have this day, this month, and what can we do to reduce that number? And one of the points I was trying to make about testing in general is that, number one, we have fewer and fewer people who I believe will agree to be tested today. And that some of the dropping testing numbers we're seeing are because the public, one, doesn't believe this is a real pandemic. I'm not going to get tested. Number two, I'm not going to turn in myself or my friends as contacts to anyone by getting tested. And if I'm not any sicker than this, forget it. And when you put that together with the fact that some people would possibly get tested if they were severely ill or even moderately ill, but on a day-to-day basis, I'm not going to do it. I'm not going to wake up every morning and, go and take my vitamin pills, do X and Y for a healthy morning and then take my test. And the only point I'm trying to raise here is not that I'm condoning that, supporting that, thinking that should be a reason we do or don't do something, but if that's a large proportion of our population, then that's a challenge. Because in the end, that then limits the ability of this to have a big impact. And far too often we have this fantastical kind of approach to life where we do find the magic bullet. The pixie dust is in the jar. So I'm a public health guy that basically I want to see that we can make a real difference here, whether if it's in 25 or 30% of the population, but I want to get a handle on that. And too much of this testing has been sold as this could fundamentally change the course of the pandemic. It simply cannot. And the people who are supporting this and moving this are people who have never been in the public health trenches in their life. And I think that's an important point, because those of us that have would say, we are willing to take whatever tools, but this is a challenge. And so I think that's the important point. The second thing is, if people are tested, will they change their behavior? And we have data from other areas of science that say, if I get tested and I'm tested today negative and I'm tested tomorrow negative, and I'm tested tomorrow negative and the day after that negative, it begins to reinforce my behavior in a way that says I'm kind of invincible. And we've not really studied that. We have looked at that with HIV. We've looked at that with other diseases where that clearly was an issue. And so one of the challenges we have is, again, not to say we shouldn't explore this, not to say this isn't something we shouldn't consider, but don't automatically assume that testing is always going to give you the result you think, that somebody will get picked up positive and that immediately will get them out of the pool. What I'm worried about is, for many of them, it'll keep them in the pool, because as long as they're test negative, they'll just stay out there doing high-risk behavior till they do become positive. And that's the challenge, that surely it would be great at that point if they don't transmit to others, but why did they stay in that pool to begin with? That test enabled them in a way, and it's almost like a crutch to do that. So those are the reasons. Finally, I just want to say, this is where I get really frustrated, is related to the issues of test licensure. Many of you know I wrote an op-ed in the New York Times in April talking about how the FDA approval for testing for COVID-19 was like the wild, wild west. I have not changed my opinion on that. So last week, when the Abbott Binox test, a lateral flow antigen point of care test, was approved under emergency use authorization, I saw so many people saying, aha, this is the rapid test we need, this is what it's at. How ironic. This thing was approved based on 35 positive sample evaluation. And I can tell you that although they report a sensitivity of 97%, having gotten 34 of 35, if you couldn't do that under those kind of settings, you really have a problem. But if you look at the Binox Abbott test for influenza, it has been a disaster with 50 to 70% sensitivity, even though it says it's much higher. The CDC says right on their website that you should avoid these types of tests for diagnostic purposes because of their lack of sensitivity for influenza. And we have no reason to think that this is going to be any better for COVID-19. And so at this point, it's ironic that it was approved for diagnostic purposes, ordered by a physician, when that's the last thing you want to use it for because of the low sensitivity. Now, if you want to use it as a screening test, just to say, okay, I'm going to put it in out there, and just let people use it, and I won't catch everybody, but if I can catch 50 to 70%, that's great. But again, it just amazes me how the media went off on this, took right away an answer as, oh boy, this is the next new big thing. They just weren't aware of it. Even a number of the science reporters didn't understand the challenges with lateral flow testing for antigens as point of care. And the flu people all knew right away what was going on. So that test also shouldn't be used on the diagnostic side. So it's not going to help us with sick people who need testing. It should never be used in that setting. And again, we still are lacking the kind of breakthrough technologies we need for point of care testing for clinically ill people.